Bismillahirrahmanirrahim. My name is Dr. Fawad Farooq, and today we are discussing some basics of shock management, a very important subject at every level of care and for every specialty. And what really it means, it's very important to understand, because most of the time we deal with it but not appropriately. And shock or pre-shock, these two things are very important. Every low blood pressure is not shock. That is again very important to understand. Starting with this case scenario, a 50 years male, known case of hypertensive heart disease with EF of 30% on routine medications, presented with 3 days of fever and vomiting, feeling slight, dizzy on examination, blood pressure 80/50, how to proceed. And commonly, these kind of patients who have their echo report with them are showing EF of 30%. The common mistake, the ER resident think that this is a cardiogenic shock. And he starts either an inotrope without properly assessing the patient. And I deliberately kept this scenario a bit complex to have a tinge of everything in it if you are really assessing, but with incomplete details. So what you need to know, first you need to understand shock pathophysiology. Why a patient develop hypotension or shock. That is very important to understand. Now, firstly, when you see a patient with low blood pressure, the prime objective is to diagnose, is he in shock or not? Because every low blood pressure is not shock. That's again very important. So what is shock? It's a condition where the perfusion of organ is too low to meet the metabolic demands and lead to anaerobic metabolism. So that means just low blood pressure numbers are not shock unless and until your patient has evidence of low perfusion, which is cold, clammy skin, metal oxidation, and oliguria, less than 30 ml per hour. In other words, blood flow and oxygen delivery to the body is low along with low blood pressure. That's very important to have. So first, your assessment for a low blood pressure patient is to assess him, is he in shock or not, or is just a blood pressure number which is low. Then to understand the shock, what we have to really understand what are the things which are constituting blood pressure. We know that blood pressure is a combination of cardiac output and systemic vascular resistance. So it's very important to understand that you have to know what is blood pressure. As we described, that blood pressure is a combination of cardiac output and systemic vascular resistance. And whenever you are seeing or trying to assess a patient with low blood pressure, so you have to look for these things. That is, what's the status? First, you have to look for what's the status of systemic vascular resistance. Because there are a lot of conditions in which your cardiac output is okay, that the things which are constituting the cardiac output are normal, but the only problem is with systemic vascular resistance, severe vasodilatation, anaphylactic reactions, heterogenic vasodilatation. So that you have to look for drugs or reaction to drugs. So these are the things you have to look for systemic vascular resistance. Then if the blood pressure is low, then either the cardiac output is low or systemic vascular resistance is low. We already have talked about systemic vascular resistance, and then you need to know what are the conditions which lowers systemic vascular resistance despite of a normal cardiac output. Now, commonly, as the sepsis, spinal cord injury, vasodilatation, anesthesia, anaphylaxis, so that you have to look for in your patient. How to assess clinically: is your patient warm, pink, hyperdynamic heart? If systemic vascular resistance is high, if it's high, your patient will be having cold and clammy skin. That's an indirect hint towards it. So if that's cold patient you're dealing with, like the scenario which I have described in front of you, with mental obtundation and oliguria, then you can think of that there's systemic vascular resistance is already on its maximum, because that's why your patient is having cold clammy skin. Then you have to look for cardiac output. And cardiac output is a combination of heart rate and stroke volume. Now, when we say heart rate, because to have a good, adequate cardiac output, you need a normal heart rate between 60 to 40. Extremes of heart rate, meaning arrhythmias, can lead to hypertension. Severe bradycardia, severe tachycardia, with all the things normal you can have. So you have to look for heart rate issue, meaning by patient's pulse rate and rhythm. You have to exclude severe bradycardia and tachycardia in hypotensive and shock patient. If that is normal, then you should be coming to stroke volume. Stroke volume is the amount of blood ejected by each ventricle during each beat. And what are the things needed for a normal stroke volume? Let's see. Heart rate problem we already have discussed. Now, stroke volume is dependent on preload, the amount of blood coming to the heart or amount of volume coming to the heart, filling the heart in diastole, how well the ventricles are contracting, the contractility of the heart. And thirdly, valve function. Is there any regurgitation or stenosis which is causing hindrance in ejection of blood from the ventricle into the aorta? These are the three components which govern stroke volume. So that means you have to look for these things as well. So stroke volume, preload and contractility, we can address if there is something wrong with volume, dehydration, blood loss, contractility, there's transient or permanent issues with the heart. But you can't change valve function. So a good examination is also needed in your patient, whether he's having any valvular pathology, and an echocardiogram at that moment. So in summary, when you are dealing a shock patient, these are the components you have to look for. That the things which are making blood pressure, which are the constituent of blood pressure, which is, let's revise again, BP, cardiac output into systemic vascular resistance. So start by looking at systemic vascular resistance. Is it low, high, or any condition which can affect systemic vascular resistance may lead to hypotension. Then cardiac output, which is a combination of heart rate into stroke volume. So judge heart rate status, exclude severe bradycardia, severe tachycardia, rhythm issues. Then look for stroke volume. Stroke volume depends on preload, contractility, and valve function. So you have to look for all these things as well in a patient. Low blood pressure, concluding, is conditioned with hypoperfusion. And that's why, considering this physiology and the pathophysiology, you have to classify your patient. If he is in hypotension with evidence of shock, you have to divide. Is he having hypovolemic, distributed, cardiogenic, obstructive? And cardiogenic usually results from pump failure. And most of the time in cardiac patient, we think that this patient has pump failure. No, dear. You have to look for. Sometimes I've seen patients with severe bradycardia, severe tachycardia, AF with fast ventricular rate leading to shock. You have to address that rhythm, not giving inotropes straight away. Similarly, in a cardiac patient can have fever, sepsis, and all other things, a distributed element to the shock. He can have even dehydration, vomiting, diarrhea, such things which can lead to with all those drugs. So that means, in conclusion, we can say that cardiogenic shock, although we know that there are a lot of pathophysiologies there, but I'm just coming back to our scenario, with which I started. 50 years male, hypertensive heart disease, VF 30%, taking routine medication. Now 3 days of fever and vomiting, even dehydration, dizziness on examination, BP 80-50. But even with that 80-50 blood pressure, you have to judge whether he is in shock or not. So in summary, I would say that when dealing a patient with low blood pressure and shock, you have to judge all the components which are forming blood pressure. Thank you very much for